Good morning, everyone. Thank you for joining us for this week's virtual journal club. My name is JP Brito, an endocrinologist at Mayo Clinic and co-host of this virtual series. Today we have an exciting and important topic to discuss. We're going to delve into predicting differentiated thyroid cancer outcomes, in particularly a data-driven approach that is part of a prospective multicenter study. And for that, we have two fantastic speakers. We have the author of this paper, Dr. Giorgio Grani, and we have an expert discussant, Dr. Johnson Thomas. Let me first introduce Dr. Grani, and then we'll be introducing Dr. Thomas. Dr. Giorgio Grani is currently an assistant professor of internal medicine at Sapienza University of Rome. His main research interest is in the study of thyroid nodule and thyroid cancer, particularly imaging and medical management. He's also an associate editor of the international journal Endocrine, member of the editorial board of Thyroid, Clinical Thyroidology, and JCM Case Reports, and regularly serves as a reviewer for other journals. Dr. Johnson Thomas, our discussant, is the section chair of the Mercy Endocrinology, Springfield, Missouri. He is also the associate faculty of Missouri State University, where he collaborates with faculty and the biology department to create novel therapeutic agents. Dr. Thomas practices general endocrinology with a focus on thyroid nodule and thyroid cancer. He has published in peer-reviewed journals and has presented in national meetings. He is the recipient of the Kenneth Simsick Award for Academic Excellence in Endocrinology and the Research of the Year from Mercy Ministry. His research focuses on molecular markers, radioactive iodine-resistant thyroid cancer, minimally invasive treatment for thyroid nodules, and the use of artificial intelligence in thyroidology. Dr. Thomas also written reviews and book chapters on the application of AI in thyroidology. With that, I welcome our speakers, our audience. I will first pass it to you, Dr. Grani. Thank you.
Thank you, Dr. Bido, for your kind introduction, and thank you to the organizers for inviting me to present our data on this approach to refine our prediction of differentiated thyroid cancer outcomes that we have published earlier this year in JCM. As you can see, this is a collaborative effort, is a multi-center study, and it is important to clarify some issues. First of all, I will cover why we decide to expand risk stratification for thyroid cancer. We have multiple tools, multiple instruments, so why we feel the need to improve them. Then I will briefly cover the methods and both the dataset we used and the models we tried to apply. Then I will briefly discuss the main results, and I also give you a brief overview on the known limitations and potential biases that are present when we try to apply this kind of methods in real clinical practice. So first of all, why we decide to work on the prediction of thyroid cancer outcome? I think it's a crucial and important issue because we know that the vast majority, most of our patients are actually low risk of structural disease, low risk of persistent or recurrent disease. And so it's important to avoid overdiagnosis and overtreatment of low-risk patients. At the same time, it's important to predict the small subset of patients who will benefit from a more aggressive follow-up protocol. Furthermore, the system that is the most used today is the system proposed by the American Thyroid Association guidelines, is mainly based on expert opinion or heterogeneous literature data, mainly derived by tertiary referral centers and retrospective data. Furthermore, there is a growing number of papers that focused on the inclusion of other features, for example, age, gender, and discussed the real prognostic impact of some other features that are actually included in the ADA system. So our general aim was to develop a comprehensive data-driven prediction model able to capture all the available features in our real-world observational prospective dataset. And what is the ITCO dataset? ITCO coordinates prospective study, observational, which is based on a web-based database of thyroid cancer patients, including differentiated thyroid cancer, polydifferentiated thyroid cancer, but also anaplastic and medullary, with the aim to, I will say, to capture all the diagnosis of thyroid cancer in Italy and the way in which thyroid cancer is treated in Italy. We include all newly diagnosed thyroid tumors at the time of initial diagnosis, and the data collection is prospective and observational. It means that the data are included in the database at a baseline at the time of the initial treatment and include patient demographics, biometrics, tumor surgical pathology, and the initial treatment approach. After that, we collect the data of the various follow-up visits to estimate, to calculate the response of treatment at several time points. We have some time points that are required by the study protocol that are 1 year, 3 years, 5 years, and 10 years after the initial treatment. How many patients we have included today in the database? We have more than 12,000 patients today, collected by more than 50 clinical sites in all our country that represent almost all the region of our country. So we are also trying to detect any geographic variability and also the potential different approaches that are applied by academic centers and local centers. For this specific study, we decided to include all consecutive cases with histological confirmation of differentiated thyroid cancer and at least one follow-up visit. Our data cutoff was in November 2019, so we had at the time about 5,000 patients, and we decided to include all the data available in the database, including histopathology, mutational data, clinical presentation, family history, and all the data available in the dataset to estimate the risk of persistent or recurrent disease. We first of all tried to generate a model including all the available variables. This was because we tried to avoid any personal human choice and to let the models to work in a truly unbiased way. But we soon realized that this was not possible because, for example, we had to exclude in the second model the variables derived from radioiodine treatment. First of all, because not all the patients underwent radioiodine ablation, and furthermore, because the treatment choice itself was going to alter the risk, or at least the perceived risk, of persistent or recurrent disease. So there was no independence between the predictor and the reference standard that we are going to predict. And what is the reference standard? Our patients are classified according to the response to treatment categories that are proposed by the ATA guidelines. To be more precise, the ATA guidelines include the response to treatment classification only for patients undergoing total thyroidectomy and radioiodine ablation. while for other patients undergoing total thyroidectomy alone or lobectomy, we adopted the cutoff proposed by the European Society of Medical Oncology guidelines. And these cutoffs were substantially the ones proposed by the works of Tacciol and Momesto on this subset of patients. And which kind of problem have this kind of classification? First of all, is unbalanced. And this is a problem that is common in all medical application of machine learning and artificial intelligence. I mean that only a small subset of our patients are actually, for example, diseased, or in this case, have a recurrence or a persistent disease. The second issue in our series is also that the classification may change over time. And for example, there is a potential transition between excellent response and the other intermediate response, such as intermediate indeterminate response and biochemical incomplete. So how we try to manage these? First of all, we decided to classify patient as structural incomplete response patient if they had at least one visit with structural incomplete response. On the other hand, we consider patient as excellent response to the initial treatment only if all visits available were classified as excellent responses, while the system was able to use a weighted average of the other response, excellent response, indeterminate, and biochemical incomplete response, taking into account also the presumed time frame in which each individual is in the specific class. At the end of the process, I will say that 8% of our patients were classified as structural incomplete response, 5% as biochemical incomplete response, 41% as indeterminate, and 46% as excellent response. This was a way to have a more balanced data set, because the excellent response and indeterminate response constituted a great part, but are two different classifications. And our main interest was to predict the structural incomplete response. Then we had to choose a model to achieve the better prediction. And we know that we have available an increasing number of models to derive prediction for medical tasks that are usually dichotomic predictions, with an increasing performance and decreasing interpretability. For example, at the start of our work, we decided to adopt some ensemble methods. And this was the first approach. We decided to consider all the variables available, or all the variables available with the exclusion of radioiodine-derived information, and then used a list of different models, random forest, AdaBoost, and so on, several Bayesian approach and logistic regression, and then to derive a probabilistic ensemble. This was very successful for the computer scientists, because we were able to improve the predictive performance of the ATA system, but it was completely unexplainable. So we were not able to understand why one single patient was classified at that level of specific risk. So we moved back, and we decided to adopt a less advanced model, so a simple decision tree that has a decreased performance, but a good interpretability. So we were able also to evaluate the quality of our data set. Also because our data set is multi-center and the quality of data is not verified, such as in a clinical trial, for example. This is the result of a decision tree. The system is able to decide autonomously without any human input the order in which the several predictors are used and the branching logic. So the most important features are on the top of the tree, and then decreasing importance are on the bottom, but are able to further stratify the risk of specific clusters of patients that are actually the leaf of the tree. What kind of information we may derive from this kind of graph? First of all, the feature importance. So we can estimate the role, the importance of each variable in the final prediction of our outcome of interest, in our case, the response to the initial treatment. And the feature importance is also interesting because we have a list of variables used by the decision tree. And for example, the first interesting result is that some variables not included in the ATA system actually are important predictors of outcomes of the patients. For example, age, body mass index, and also clinical information. For example, the circumstances of thyroid nodule and of thyroid cancer diagnosis, the family history of thyroid nodules and cancer, and the gender of the patients. After that, we decided to recreate with our results the concept of continuum of risk that was proposed by the American Thyroid Association guidelines. I think all of you know this arrow and this figure. It was included in the last version of the ATA guidelines to highlight the idea that even if the ATA risk stratification system is divided in 3 classes, actually each single patient may be better stratified according to their single features. But even in this case, single features are considered individually with no possibility to evaluate the interaction and the relation between the various variables. Our work was, on the contrary, able to derive some clusters of patients, taking into account the combination and the interaction of several different features. For example, at the bottom of the risk, the rates here are the rate of structural incomplete response detected during the follow-up. At the bottom of the risk, there are patients with no or less than 5 lymph node metastases. Then the increasing number of lymph node metastases and tumor size increase the risk of structural disease in our patients. For example, if we would apply this result in clinical practice, in everyday practice, we can see that a patient with less than lymph node metastasis has a risk of recurrence of about 2%, but this risk may be further modulated by BMI, for example, histology subtype, for example, oxyphilic cell carcinoma carries in our series high risk, or extrathyroidal extension that increases the risk in general up to 12%, but this risk is also modulated by tumor size. As you can see here, the extrathyroidal extension with tumor size less than 25 millimeters has a risk of 8%. On the other side, if we have patients with more than 5 lymph node metastases, the risk goes up to 25%, but also in this case, tumors with reduced size less than 29 millimeters and complete resection have a risk of 14%, while incomplete resection increases the risk to 28%, and this risk is modulated by age. Also, patients with more than 5 lymph node metastases and a tumor size more than 29 millimeters has a risk of structural incomplete response of 43%. Well, I have to acknowledge that we have several limitations for this kind of approach. First of all, I'll show now the complete list of feature importance and the complete list of the feature importance derived by the two models I've mentioned before, the one including all the data and the second one including only the data not derived by radioiodine treatment. I would highlight, for example, the issue of distant metastases. Distant metastases have a high, as expected, importance in the model with no radioiodine-derived data, but their importance decreases markedly in the model including all data. Why? Because in this model, the same information is conveyed by another variable, that is the stimulated serum Tg, that has a lot of importance. So we have to look at the list of the variables to see if different variables are actually conveying the same meaning for the clinician. Another example is the circumstances of nodal diagnosis. So the reason for clinical diagnosis, for example. This has feature importance that is substantially equal to the histology subtypes. So it's quite important. And also, it may be a proxy of occult features. I mean that the circumstances of nodal diagnosis are probably including some information that the clinicians, the surgeon, and the patient have during their discussion about treatment and are included in this kind of variable, but not in others. Other two interesting variables are the decision itself to perform radioiodine therapy and the surgical approach. The therapeutic choices are not only proxy of occult features for the same reason I've discussed a second ago, but also we could see that the therapeutic choice influences also the distribution of patients in the a response to treatment categories. Because, as you can see, both biochemical incomplete response and indeterminate response classification are influenced by the thyroglobulin levels that are different in patients with radioiodine ablation, with thyroidectomy alone, or lobectomy. So also our reference standard is modified by our treatment choice. In conclusion, I would say that our results have demonstrated that the current risk stratification systems may be complemented and improved by the inclusion of other demographic, clinical, and anthropometric data. And in general, that a data-driven approach may improve the prediction of response to treatment, in particular because a complete set of variables allows for a more precise clustering of patients. My last word is only to thank all the people working on this data collection, because as you can imagine, this is an important amount of work, and also to thank the data science group here at Sapienza University of Rome, in particular Michele Gentili and Federico Siciliano, who shares first authorship with me on this paper. And thank you for your attention.
I would like to first thank the organizers for inviting me to discuss this important paper. And I would like to congratulate Dr. Grani and his colleagues for this excellent paper. But also congratulate him on the recent international thyroids paper with the lexicon. I think that's the right way to go. Congratulations on that paper. So without further ado, we'll go into discussing this paper. So when a patient is diagnosed with thyroid cancer, they want to know what is the next step in treatment. Is this going to come back? And what is the follow-up that's going to look like? These are the classical questions that we get from a thyroid cancer patient. From a physician standpoint, we're trying to avoid over-treatment in low-risk thyroid cancers, but at the same time, we don't want to miss aggressive thyroid cancers. These are the two perspectives that I'm trying to expound here. And there is an unmet need addressing these questions. Again, risk stratification and risk of recurrence is dynamic. It can change as the disease progresses, and we need tools that could actually help us explain these problems and predict the outcomes, possible outcomes, using these tools. Now, we all use the American Thyroid Association guidelines to predict recurrence. The excellent graph showed by Dr. Grani is what we always use. But let's look at some prior work that was done before the publication of ATA. Here you can see 5 different publications from different parts of the world trying to predict thyroid cancer recurrence. And here some of them, Welsh and his colleagues used about 25 prognostic factors. So what they did was, if you have a certain feature, you'll add a point. If you had another feature that actually makes the recurrence less, you will subtract a point. So that was a comprehensive study with 25 factors. But as you can imagine, the more the factors goes into the study, it's hard to incorporate that in clinical practice. Onitilo and colleagues from actually United States, they used 4 features, which are actually histopathology, age, regional lymph nodes, and primary tumor size. Later in 2012, Buffett and his colleagues used about 1,669 patients to predict the recurrence using gender, multifocality, lymph nodes, and presence of metastasis. So that was kind of a 3-variable prediction system. Later, again, the same year, Niemeyer and his colleagues used location of tumor. If it's actually superficial, it actually got a higher rank. Presence of BRAF mutation, multifocality. They also included fibrosis inside the tumor as a risk factor. Finally, Kim and his colleagues used more like a linear regression model using age, sex, extrathyroid extension, and preoperative lymph node. So, and they all had different rates of recurrence ranging from 18 to 4.1, but had long follow-up and up to 20 years in certain cases. So this is one of the prior work that was summarized in this table. Now, as you can see, in the American Thyroid Association guideline and the paper presented by Dr. Grani, the first few of them are kind of what we use in TNM classification. So the other study I'm going to discuss is published in 2019. And in this study, they tried to use the AJCC 8th edition for predicting recurrence. So usually we use the TNM staging for predicting mortality. So they were like, well, can we use this to predict recurrence? In this study, they included 4,124 patients from 1985 to 2015 and had a median follow-up of 7 years. In the whole cohort, only 6.4% developed recurrence. And the different recurrence rate you can see here. In stage 1 patients, only 5.2% developed recurrence. In stage 3 and stage 4, it was 50% or above. And they concluded that we could actually use the TNM staging, AJCC 8th edition, to kind of predict the recurrence very well. Now, another paper which came out recently in June of 2023, they actually used nomogram to predict the recurrence. Here they had 617 nodules in the training set, and they used that model created to predict 102 nodules. They had 2 different models. One was to predict biochemical incomplete recurrence. The next one was structural recurrence. And we see some common variables that is used across the studies. Here they use sex, age at diagnosis, tumor size, and extrathyroidal extension and lymph node ratio to predict biochemical incomplete response. And to predict structural recurrence, they again use tumor size, extrathyroidal extension, BRAF mutation, metastatic lymph nodes, and lymph nodes ratio. Now, let's come to the study by Dr. Grani, and he actually went through this in much detail, so I'm not going to spend too much study on this, but I think this is the right step in moving towards precision medicine. They used 4,773 patients, median follow-up was 26 months, and it was a large cohort. And it was able to, this model was able to increase the sensitivity of high-risk structural disease recurrence from 37% to 49% when compared to the ATA prediction, and for low risk and negative predictive value increased by 3%. And they also introduced some novel factors which could increase the precision of prediction, which were age, body mass index, tumor size, sex, family history, surgical approach, cytology, and circumstances of diagnosis. So here I would like to pause and like to explain the importance of having this thyroid cancer registry. I am envious of Giorgio and his team to have put this big thyroid cancer registry. I wish we all have these kind of registries to draw conclusions. And hopefully in the future, we can create these large thyroid cancer registries and collaborate across the board. And having these kind of large registries helps us to understand the factors that influence the prognosis of thyroid cancer. And as you can see, they have more than 10,000 patients with histologically confirmed diagnosis. They have academic and non-academic centers. And this is kind of more indicative of real-world performance. And this is what we are looking in the data that we want to predict from. Now, coming to the crux of the paper, we are trying to compare the American Thyroid Association continuum of risk versus the data-derived clusters. Even though they are dissimilar, there are also a lot of similarities. If you look at all these prediction models, TNM classification, ATA classification, and the one presented by Dr. Grani today, there's a lot of similarities. So if you look at the lower area in the lower box where you have less than 5 lymph node metastasis, and look at the areas marked by me as red in this slide. If you look at the top red mark, T3, minor extrathyroidal extension, and it actually, and if you go down a little bit, you can see less than 5 lymph nodes involved. So up to that, that's where the first cutoff kind of matches Dr. Grani's paper, and they have very similar rate of recurrence. In the ATA paper, it says 3 to 8%, and in this paper, 8%. But as it goes up, we can see there is more difference. As we add more variables, you're predicting with more precision, and it goes up to 64%. And here in the ATA category, 55%. It also depends, does it matter if it crosses a certain threshold? How do we define that threshold in treating? For example, if it's more than 40%, it's not acceptable for the patient, and then we go on to radioactive iodine treatment or something like that, or maybe even 20% is not acceptable for a patient. So it's less of what the actual prediction is. It's actually communicating with the patient the risk and finding out common grounds in treating in practical terms. Now, this is actually very important. Dr. Grani actually alluded to quite a bit of time to explaining this, why they use the decision tree algorithm. There are more fanciful models that we can use with better predictions, but in medicine, there is a tendency to use algorithms which are explainable. This is still being debated. Do we really need to have explainable models, or we want to have models which are more accurate in the treatment of our patients? So this decision tree, as Dr. Grani showed, it's very explainable. You can see where the tree branches off, and you're able to visualize it, understand it, and we can also find the important features. But it also has some potential issues. For example, categorical variables, if they are not arranged in hierarchical order, or in machine learning term, if it's also not one-hot encoded, the tree can split not evenly. For example, one of the variables that was used is the extent of surgery, right? Some patients may have lobectomy, some may have total thyroidectomy. So, and if that's not arranged in a hierarchical order, 0, 1, 2, 3, depending on the risk, that could have an impact on decision tree. But it can be avoided by statistical methods or doing one-hot encoding. So that's something that I haven't seen in the paper, but I'm sure they have thought about it. Now, this is a great paper. Here I'm nitpicking. So there are some limitations. It's done in an Italian population. It may not be transferable to another population. For example, if you look at the BMI cutoff, it might be very different in another country with increased chance of obesity, or the BMI is very variable. So the cutoff could change when we extrapolate it into a different population. Now, the treatment centers were not given any guidance on treatment, so they could do what is best for their patient based on the available data. So this creates a lot of variability, but this could also be a strength because it's kind of what happens in real world. And compared to certain other studies that I pointed out, this study has low median follow-up. But the beauty of having this registry is Dr. Grani and colleagues can actually extrapolate this into the future and follow these patients and make this model even stronger when they have more data. Another thing which is not particularly a problem just for this, for every model that uses these kind of data, is there will be subjective variables. For example, one of this thing that will show recurrence is suspicious lymph nodes in ultrasound. And that is a subjective thing. Some might look at a lymph node and say, well, yeah, that doesn't look that too bad. I'm not going to biopsy it. Or some might look at the same lymph node and say, well, it does have some features. I don't want to miss anything, and I want to biopsy it. So similarly, when a potential recurrence is spotted by a physician, it's up to the physician to do a biopsy or surgery or to do radioactive iodine treatment. So if they don't think it's a recurrence, they might not biopsy it. If they don't biopsy it, we do not have a diagnosis. These are potential problems, but this is going to be a problem in real world circumstances. Another thing that I could think of is nowadays we are using active surveillance for many of our patients, and we are moving away from total thyroidectomy and radioactive iodine for low risk cancers to more of lobectomies. And in this study, there is not much of lobectomies, as there is a certain percentage of lobectomies. So can this be extrapolated into the future where we will have more of lobectomies? Another thing is the guidelines are also changing. For example, what's an indeterminate response, or what is the TG cutoff that we should be using? There was a recent discussion in the same Thyroid's platform about, should it be 5 or should it be 30? So those things will change, but having this database, they can adapt it if something changes in the future. Now, again, in the paper, Dr. Grani also rightly points out, sometimes they have to use weighted average for mixed response. This is not a good statistical idea, but then again, this is the best that they could do under those circumstances. Now that we have this as an internal validation study, I hope they can do external validation study and get it validated in external data sets. Now, after reading this, I have a few questions for Dr. Grani. One of my questions was that what is exactly being predicted? I think I got the answer from his presentation, but hopefully Dr. Grani can explain this a little bit more. Are we predicting the probability of recurrence or the probability of non-excellence response? Now, another thing I noted was that initially they used a 5-fold cross-validation to test it. Now, when you're doing 5-fold cross-validation, you're actually creating 5 different models. It's not a single model. But later in the study, it uses a single model was used for each of these. So how was that model selected? I was not able to find that. Hopefully, Dr. Grani can explain that. And the other thing I want to point out is, if the model was tested on the training data, it may not give us accurate results. So many studies have shown that if you're actually using the same training data to test it, the model might have memorized some of the data, and it might be giving that data, and sometimes it's overfitted. One way to avoid is doing that 5-fold cross-validation, but you don't get a single model from it. You can by averaging, and there are different techniques to do that. So explaining that in the paper will also be helpful for the future readers. And here in our practice, most of our patients get a biopsy, and many of them, when they have indeterminate or suspicious nodules, they end up having molecular markers. And for example, if they come up with BRAF and TERT mutation, we know that it's going to be aggressive, and the physician might be more aggressive in treating that. So including those things in the future, I hope it can make it better and give us more prognostic information. Now, overall, I think this paper addresses an unmet need, and I hope that the future guidelines and papers include the variables that was given by Dr. Grani and his colleagues and make this prediction better for our patients and for the treating physicians. Now I will turn it back to Dr. Grani to answer these questions. Again, great paper, Dr. Grani. Thank you.
Fantastic.
Thank you.
I know, just thank you, Dr. Grani, and thank you, Dr. Thomas, for fantastic presentation. So yes, sorry for interruption, Dr. Grani. You can answer these easy questions.
Just to thank you, Dr. Thomas, for your overview of the work, because you found all the limitations, not all the limitations, but someone I've spoken about and some other who've discovered. And it's true, we don't have an external test. We just have an internal cross-fold validation. So the model was tested on the same data set. So we don't have an external validation. We are now performing an external validation of other patients, also using a web-based application. So to be able to validate our results in different populations, I mean non-Italian populations. We are working on it. Then molecular markers. Actually, we have variables about molecular alteration in our dataset, but the number of patients with this data is lower in Italy than in the United States, because it's not standard of care here in Italy to perform molecular analysis for indeterminate nodules. So we have this kind of information only for a small fraction of patients. Furthermore, these patients are also selected because usually we perform next generation sequencing, for example, in tissues of patients who are likely to progress to systemic treatment. So for now, it's not possible to include this information. I mean, it's in the dataset, but it was excluded by the decision tree. And what is being predicted? Actually, the system was generated to predict the whole series of categories. So I mean, excellent response, indeterminate, biochemical incomplete, and structural incomplete in decreasing order of desirability. I mean, at the end, I presented in the paper only the rate of structural incomplete response. So to briefly answer, for the generation of the tree, all the 4 categories were considered, but then we presented only the rate of structural incomplete response. This was a way to, in some way, taking into account that some of the patients with biochemical incomplete response and some of the patients with indeterminate response will be developing later potential recurrence. It's also true that, as you correctly pointed out, also the structural incomplete response is not so real. In machine learning, usually the computer scientists speak about ground truth. In our case, this is not ground truth, because also the classification of structural incomplete response may be subjective. So this is true for these reasons. Last issue is the dynamic stratification. We have also tried to introduce in our model the results of the previous visit to predict the subsequent response to treatment. And it is always working clearly, because it's true that the dynamic risk stratification improves our prediction for the patients, but we decided to focus only on baseline data because our follow-up time is quite short. So for the first model, we tried to use only baseline data.
Excellent answers, Dr. Grani. I think you answered all my questions. I hope if one of the viewers have wants to collaborate and do external validation of this model, I hope they can reach out to you and collaborate in the future.
And while we wait for our questions from the audience, first, again, congratulations for the paper. And one question that comes is, when we are talking about predicting something, I feel like the groups are very different, and that's Johnson was showing how variable this accuracy of the models are of previous papers and things like that. And I do feel, for instance, that if you were to have total thyroidectomy plus central neck dissection, you will have a different predictive power of lymph node metastasis, as opposed to somebody that might not have a central neck dissection. And that treatment dictates prognosis to some extent and how predictive power we have for the variables. So it comes to mind the sense that in the work of predicting things, I think we have to perhaps, and I like the fact that you incorporated factors of treatment like surgery to understand the outcome, because I do think that the treatment has not been considered. Radioactive iodine, yes, is typically considered, even though people do sensitivity analysis, take it out, or just add it to the model. But surgery has not been there, although surgery dictates which variables are present. So I do think that that is a little bit of heterogeneity of the groups that we have not been able to solve. And I think adds a little bit of inconsistency and imprecision to the predictive models. What are your thoughts, Giorgio?
Yes, this is true, because also in this case, we have many different surgeons, for example, with many different approaches to the central compartment, for example. So from some centers, all patients are still submitted to central compartment dissection. And we decided to include in the model also the treatment choice. I mean, also the choice of the surgeon about neck dissection, and also the number of resected lymph nodes. This is an attempt to take into account this information, and in fact, the surgical approach, the completeness of resection, but also the surgical approach that means total thyroidectomy, near total thyroidectomy, lobectomy, and neck dissection, central and lateral neck dissection, is going to actually change the outcomes. But I think that it's also a proxy of some information that derives from the discussion between the patient, the clinician, and the surgeon, because it's also possible that the resection is performed if the sonography is uncertain, and so on. Information that we don't have directly in the data set, but are reflected by the surgical choice.
No, yes, agree. Just one question. You presented this a figure of previous models, previous papers, and what do you think we should be using? Because we're gonna have in the area of precision medicine and big data, I think more models like this coming from the same group that Georgia's group, maybe United States, Australia, people are developing these registries and probably prospective ones and predict thyroid cancer recurrence. How we compare across these models? Should we start understanding AUCs, area under the curves, to trying to see how they compare to each other? Because this is the beginning, I think, of many more models to come.
Yeah, it's a easy question, but a hard one to answer. As you know, there is no way we can compare a 25 factor model to a 3-factor model other than just looking at the outcome, right? But it also boils down to what can we use when we are seeing a patient eye to eye in the clinic, right? Is that model available to us? Is that giving a reasonable predictions? There is this famous quote which goes that all models are wrong except when it is right. So we are predicting probabilities here. So when we want access to this model at the point of care, and it should have reasonable predictive power, so we can counsel the patient, like this is what's going to happen, and these are the probabilities. Just like JP has created the guideline for treating Graves' disease, these are the options, these are the potential problems. So these are tools to present to the patient and discuss what path to take, right? So I think these should be taken as educational tools too. Now, how do we compare? The second part is how do we compare these models? Using external validation study is kind of an incomplete proxy for that. But I would recommend, if we are going to use it, we need to first test it in our population. To do that, you need to have your own registry or at least a smaller data set to see whether it compares to the presented study. So, but I am leaning more towards explainable models rather than which is more accuracy, because when it is wrong, we don't know. We can't go back and say, okay, this is the reason it failed. So I prefer explainable models. I prefer models which has less variables, but important variables going into it. That makes it easy for the practicing clinician to input those variables and get a result and make it useful at the point of care. Hopefully, Dr. Grani and group can make it as a web-based model with privacy-preserving features. Nowadays, you can actually run the models in the browser, especially a decision tree model, so we don't have to worry about data going across the cloud and stuff like that. So that's what I'm hoping to happen in the future. But great question, JP.
Very good. So no, a fantastic response. So assessing the models from utility more than anything else. So I think this is well taken. Well, we are up to the hour. Thank you very much, Giorgio and Johnson. Fantastic topic and discussion. And thank you again for accepting our invitation. And thank you to the audience for participating. See you next week.